I am Jeff Hall, the Senior Editor for Diagnostic Imaging. Welcome to our latest Diagnostic Imaging Practice Academy, AI and Radiology, where we are and where we need to go. We have two exciting sessions on tap to deliver some insights and actionable tips that can help you in your practice. Our program today is being hosted by Diagnostic Imaging and sponsored by Rapid AI. Please refer to our exhibit hall located on the left side of your screen to learn more information about our sponsor. Before we get started, some quick logistical items. We want this activity to be interactive. If you have questions throughout the program, click on the Ask a Question button on the left side of your screen, type in your question, and click Submit. We'll be monitoring these questions throughout today's program. For navigation purposes, if you prefer to see our speakers in a larger format, all you need to do is click the square button that will appear on the bottom right of the video window when you hover your mouse over it. Click Escape on your keyboard to revert back to the smaller player. Finally, the program materials will be available to registrants. After the conclusion of the program, each registrant will receive an email with instructions on how to access the materials. Okay, now let's talk about our exciting sessions. Here's what we have on tap for today. Clinical AI beyond detection, extending radiology's impact across the care pathway, and beyond detection, AI that evolves radiology. Now let's get down to business with our first session, Clinical AI beyond detection, extending radiology's impact across the care pathway, brought to you by Rapid AI. Welcome to our latest Diagnostic Imaging Practice Academy webinar, AI and Radiology, where we are and where we need to go, with support from Rapid AI. I am Jeff Hall, the Senior Editor for Diagnostic Imaging. I am pleased to introduce our first two speakers for today's Practice Academy session. Dr. Sina De Gargani is a professor of radiology and associate chair of informatics at Stanford University. He is the medical informatics director of Stanford Healthcare Office of the CMIO. He is also affiliate faculty of the Artificial Intelligence in Medicine and Imaging Center at Stanford University. Dr. Raza Mushtaq is an associate professor of neuroradiology, director of head and neck imaging, and associate program director of the Neuroradiology Fellowship at the Barrow Neurological Institute in Phoenix, Arizona. A quick reminder that Dr. Mushtaq and Dr. De Gargani will have some time to answer audience questions at the end of their presentations. If you'd like to ask the presenters a question, please click on the Ask a Question button on the left side of your screen, type in your question, and click Submit. With that, I will go ahead and turn things over to Dr. De Gargani.
Thank you, Jeff, and thank you to Rapid AI as well as to Diagnostic Imaging, and of course, thank you very much to the audience. I am pleased to be here. Thank you to my co-presenter, Dr. Mushtaq. Obviously, a number of topics of great importance and relevance to imaging practice in the modern era. And as we think about clinical AI, which is a term or a concept hard for us to escape nowadays, we want to start with a problem that we think is, while open, potentially solvable with tools and functionality that's being presented by Rapid AI. I think most in the audience are probably aware, perhaps firsthand, of some of these statistics in imaging and in radiology departments in general, showing the rapidly growing burden upon imaging practices, radiologists, and the entire allied fleet of practitioners in medical imaging nowadays. In many respects, due to or traceable to inefficiencies of an altogether fragmented system, leading to backlogs that may be difficult to relieve cognitive burden and understaffing that lead to chronic difficulties in recruitment for radiology departments, mostly traceable to the staggering increase in volume. And for better or worse, radiology is not alone as a medical imaging department. This is, in many respects, relatable and epidemic throughout healthcare in general. Similar consequences and effects are seen throughout the healthcare system in the United States and abroad. And this motivates much of what we're going to talk about today, the need to begin thinking about solutions not just for radiology, but again, more holistically for the entire healthcare system. And as I mentioned, Rapid, of course, started as a stroke imaging company. We're all familiar with that part of its genome, and that legacy continues as an industry leader in perfusion imaging. But we really want to stress that Rapid today is much more than just a rapid perfusion, which many in the audience may have grown accustomed to using, may have trained with, and may rely on day in and day out. And one point worth stressing when thinking about platform solutions is that if you have rapid perfusion installed today, you have the platform and the infrastructure necessary to take advantage of all of the tools and the functionality that we're going to present in the course of the following slides, potentially with no additional IT or security review. And we're talking now about a more comprehensive, holistic solution that includes the clinical depth and platform integration that makes Rapid unique in an otherwise pretty crowded field in medical imaging and IT infrastructure in the present era. So I'll begin with just a few words about the IT infrastructure, and then move more into some of the clinical solutions that you may expect and find advantageous in your workflow. So Rapid is built from the ground up to maximize clinical impact and to allow and optimize continuity in your workflow. And like many such solutions, when the imaging comes from the scanner, we need to find a way to feed this directly into an orchestrator that can oversee the fate and the disposition of your imaging to any of a number of different endpoints within your IT infrastructure. And the orchestrator will determine where appropriate AI can be run on certain types of imaging, certain classes of examinations. This can be made very granular. This can be made very coarse and generalizable. But in any case, once processed, the imaging will go to, or rather, I should say, once received from the modality, the imaging will go to the cloud for fast processing on the back end, and then back down to the users to the interfaces that you're used to using in practice in a way that is seamless and innocuous, really optimized to minimize any interruptions, any latency. And Rapid is unique by comparison to other such solutions in that it's deployed through an edge cloud configuration, which enables you to hybridize your solution in the event, for example, that the hospital, consequent to some threat, some present threat, some unanticipated threat, some maintenance necessary in infrastructure requiring that the firewalls be closed down, to reroute to on-premises servers in a manner that ensures entirely uninterrupted service for high acuity clinical cases, including stroke and others, as we'll see. And when thinking about this threat landscape, this surface is not just a theoretical one. Many healthcare systems, including potentially some with which you're familiar, have had challenges of this sort that have led to system outages, in some cases related to cyber attacks, in other cases not even due to something necessarily malicious, but in any case, in situations in which high vulnerability infrastructure like that in healthcare systems, which is the second most frequently attacked after critical manufacturing, you may see in some cases severe interruptions to critical workflow, and this can affect patient care in ways that are in some cases obvious, in some cases are not even necessarily so obvious until you experience downtime of this sort. Ascension and McLaren recently faced challenges that are very much in this vein. And these can be costly. These can be detrimental. These can affect trust of the payer system, of the patients, of the referrer base, and obviously can lead to catastrophic losses of high sensitivity data, in many cases with compromises to confidentiality of patients in your workflow. So in each of these instances, when the hospital was forced to shut down their internet, no other systems were working, but Rapid was able to continue uninterrupted because of this hybridized design that's enabled by the edge cloud. And I realize this is not an IT audience, or at least not wholly an IT audience, and so we won't get too deep into the weeds, but we do want to give a sense for your IT architects and informatics core in your institution that IT integration with Rapid, while often an afterthought for many other such companies, is really core and fundamental to the adoption strategy that's meant to allow this to generalize and scale rapidly. And so I want to kind of share some of this early, because in many respects, Rapid has taken a unique and innovative and creative approach to solving some of these integration challenges that are likely to come up if you're new to advanced AI orchestration and integration. So the Rapid Enterprise platform is designed at its core as an open, fully vendor-agnostic system, something we've all come to know and appreciate with other Rapid tools. And this makes, even when you're thinking about high-level orchestration, Rapid very easy and straightforward to add as a solution, because it does cooperate and integrate nicely with other existing hospital systems and workflows. And this is really a key differentiator that you'll see surface if you're comparing tools in real time. Now, unlike many PACS-specific solutions, those that are embedded or native to within a PACS system, or other platform types of vendors, Rapid can work with essentially any of the standards. It doesn't really matter if you're on one vendor or another, because it's using vendor-agnostic universal standards like DICOM, HL7, FHIR, and so forth, which enables you really to integrate across your ecosystem in a way that is seamless and remains secure and compliant with your overall infrastructure. So one final point I think worth making, in the event that you have research departments that have developed homegrown AI solutions, which is likely the case for many, for example, of the academic institutions and their representatives, or if a certain department elects to stick with a very specific AI solution that Rapid doesn't presently provide, Rapid has enabled tooling that facilitates plugging in any such AI tools and models into the Rapid ecosystem in a way that is fully supported still within Rapid's overarching infrastructure. So as we'll discuss a bit further in the presentation, Rapid has a number of AI partner solutions. These are presented as essentially prefabricated, off the shelf, ready to use, but in the event that you have circumstances that require a broader portfolio, Rapid supports that sort of integration as well. So a key component of the platform, and what really brings to life its functionality and ease of maintenance, is the EdgeIQ orchestration. And this is really where a lot of what we've discussed kind of comes into play. This is going to use AI-driven tools that are going to analyze, for example, the metadata within your DICOM, scanner protocols, even pixel level data, down to individual pixels, regions, anatomy, and so forth. And this is going to allow you to route the appropriate information so that the imaging links to the desired or best models from within the portfolio of tools that you may have available within your Rapid ecosystem. And this really simplifies the process of integrating these modules, all of which is happening cloud side. A unique point that is fundamental to the edge cloud deployment is that the orchestrator is going to run on-prem first, and then only send the necessary data into the cloud. So this has a number of attributes and benefits worth keeping in mind. What may not be obvious is that internet bandwidth can quickly become consumed as you scale further and further to cloud and AI solutions. So intelligently prioritizing only those portions of your data feed that are necessary for the cloud processing is going to have benefits in terms of reducing any lags and bottlenecks from overly bloated transfer protocols and so forth. And this is going to help your hospital or your server preserve critical bandwidth and storage footprint. Downstream benefits also include that any scan that may have a potential finding of interest is going to be processed, but only such scans are going to be processed. You don't have to overly cast an overly wide net, I should say. You can really customize the linkage between exam type, finding of interest and the model that you think is best suited to that kind of analysis. And this really allows for a broader level of orchestration and optimization that's not reliant simply on, let's say, naive scanner protocols, for example, to keep the AI running. It can be much more nuanced and much more expressive and customized in an adaptive sense in that respect. This means less imaging IT maintenance time. This reduces the burden on your imaging technologists, and as we said, on your bandwidth as well. And then ultimately, we're going to route results to anyone and everyone who has the necessary privileges and who benefits from those results. This can be configured to include only positive or only negative or combinations of positive and negative findings in a manner that optimizes your decision-making for full clinical decision support across the entire portfolio of tools that we're going to discuss. And that's important to stress post-deployment analysis. This is something that's unfortunately often overlooked or relegated to some future deployment. But Rapid has embedded your post-deployment performance analysis tools in your initial installation here. And this allows you really to assess the level of adoption, the performance, the possibility for post-deployment drifts in performance, and to really assess the ROI for any given tool that you may be using. If I'm not mistaken, Raza, this is something that's come up already at the BNI in your practice, and you've seen some utilization or projected some utilization of these tools. Is that right?
Yeah, definitely. This is extremely very helpful for us to monitor and make sure what we have deployed is really working. It's doing what it's supposed to do. And these are regular metrics for the system. And what's really cool is that Rapid monitors it, and there's actually alert setup that goes out both through the Rapid and to us if something does go wrong. And I think that really helps figure out and if there's any upcoming issues to really tackle them head on before they really become bigger. But what else this is really good for is being able to see the different kind of metrics, like when do we have a surge in number of studies that are being ordered. That can then help us decide how do we want to staff. Do we need more staff at a certain site? Do we need more radiologists? So all of that becomes extremely helpful from an administrative standpoint to really be able to handle the increasing volumes as something that you alluded to that's becoming increasingly more challenging.
Thank you. I appreciate the importance. And really, I think what I want to stress about all of those points is that we're looking at something much more comprehensive as an end-to-end solution for workflow, not just clinical decision support, but really something that integrates, again, with things like staffing, load balance predictions, projections, and predictive analytics. Another point I think worth making when thinking about it in this framing is that if you're an institution that's adopted widespread AI-based solutions, you'll find that if you haven't already, you'll very soon need a formalized governance structure. And this governance structure is really fundamental to the way that we oversee at this point the priorities, but also the compliance of our AI tools. And this includes not only assessing the number of cases that are processed, but really the sort of the fate, the disposition, the provenance of data, the destinations of data, and really feeling like we can assess in an anticipatory way rather than in a reactive way, deviations from intended behavior. So the fact that Rapid has really embedded so much of that functionality on the front end, I think for sites that maybe are only now moving into widespread AI adoption, will find that this really facilitates the design of a governance structure. And so I want to summarize in saying that, as you can see, the platform at this stage is really scaled and designed to grow with the imaging practice. As your AI solutions or your AI solution needs grow, so too does the ecosystem, and this can be done in a way that is modular or comprehensive and allows really the learning curve to be optimized for the end users in order to maximize the effect on patient care. And so this gives you sort of a satellite view of Rapid's algorithm portfolio today. By the end of the year, this will grow even further. So this is at best only a snapshot of what's really an extremely dynamic portfolio. And again, in many of these cases, we're seeing best-in-class performance for a lot of these tools. So for each disease, you can expect a complete solution to help you with the clinical decision support from end to end, including from the radiologist to the referrer and even potentially to the patient, as we'll see. And a lot of this has been enabled by Rapid's preemptive strategy to move out of siloed modules that can be restrictive and can impede the growth when you're moving towards a full large-scale enterprise-level solution of AI-driven tools. So this basically connects the entire stream of the care pathway. It's more than just triage, obviously, at this stage, and many in the audience are probably aware of the advanced messaging applications that allow you to bring the entire care team together so that findings, results, interpretations, and reporting are really done in unison in real time. And this impacts care for patients and for the entire care team. So again, we're beginning on the front end with initial triage, and that may primarily include stakeholders, for example, from emergency departments and radiologists, moving towards structured measurements and scoring for risk assessment, mobile capabilities to communicate those findings in an efficient way to the entire care team, tools that then will facilitate appropriate referral and follow-up, and then lastly, ultimate treatment planning for longest term capture for the entire patient care arc. So as you can probably imagine, we're going to talk about a number of stroke and also non-stroke examples in today's workflow. And from the standpoint of a radiologist or for any rad informatics representatives that might be in the audience, finding a way to present this to radiologists in a manner that isn't itself going to present a bottleneck, that isn't itself going to be so arcane and so complicated or require such a click-intensive procedure to bring data into and out of context is an important part of Rapid's solution and how to increase the adoption and suitability for real clinical workflow. And much of this is being enabled at the level of the radiologist's review, where you can view these triage modules in the PACS. That would be maybe the bare minimum necessity, but Rapid has moved quite a distance already from that initial milestone, allowing you to really interact with a comprehensive suite of imaging tools, of work list optimization tools, and even reporting tools, as we'll see a bit further, assisting ambient and intelligent reporting that allows you to really simplify what's seen in the radiologist experience without overtaking your entire PACS system. If your workflow is like so many others, you probably have limited screen real estate, and you might find that it's difficult to juggle, for example, the AI environment, the PACS system, your work list, your EHR, your reporting tools, and so forth, all within limited screen real estate. And we'll see some examples of how Rapid has brought us to solutions. An important part of this is being able to decide in a way that's sort of innocuous and streamlined with inline widgets that basically run in context. And so this means that the entire portfolio can be viewed in a very lean presentation format within a fully in context inline widget. The radiologist can then determine whether or not they want to send a certain result to the PACS for ultimate archiving, or if they wish to dismiss it because it either didn't meet some performance benchmark that was expected, or maybe it was a part of some QA or some QC and not intended for long-term archiving within the patient imaging jacket. Another large part of the burden in standard practice for radiologists is the process of communicating urgent findings when those do arise. You may have clinical coordinators, you may have reading room coordinators, or you may be looking through Epic Chat or through other such tools, but this can be time-consuming. Rapid has allowed the installation of fully inline communication tools for the entire care team based on however granular or however coarse privileges are required to bring together all individuals caring for that patient in a manner that can be communicated through mobile devices or really through the entirety of the EHR infrastructure. And this allows you to share acute findings without having to spend that additional time that might be necessary to reach a provider. Now, this also facilitates real-time sort of co-sharing and viewing through live console tools that Rapid has added to within the portfolio, whether a finding is difficult to communicate because it's subtle or an imaging number isn't visible to a referrer. You can share in real time a finding. You can annotate. You can use this potentially to facilitate even teaching conferences or working conferences like stroke and cerebrovascular imaging conferences in which you're reviewing. And this may really simplify the process of loading an entire case list, for instance, for a conference in a manner that allows you to really simplify sharing critical findings.
Thank you so much, Tina. That was great overview of how AI is really changing things. So let's see how this really looks like in a normal case and workflow. So this is what worklist prioritization looks like. And you see right off the back, it's highlighting 4 cases that it suspects something is going on. So there's suspected LVO, suspected ICH, and suspected aneurysm. And this sort of prioritization tool is extremely helpful, especially with the volumes that we see nowadays. When we are on the weekend call, I routinely come in, there's 60, 70 cases that we are starting the day with, and it's hard to say which case should I start with. Generally, we will just do oldest case first and then make our way to the newest case. But what if one of the newer cases have an urgent finding that needs to be looked at first? And it becomes extremely difficult. So, what that practically looks like, let's say you have 40 head CTs on your list, you start with number 1 and the first 20 are negative, but like case number 23 has a positive finding. By the time you get to it, it's already been an hour or 2. So having a worklist prioritization tool that bumps that case to the top of the list makes it much easier for us as radiologists, so we know which case to prioritize, which case to get through first. So this is what that looks like in practice. So we'll kind of work our way through a suspected ICH case and see what that looks like. So we start looking at the case and we see there's a big hemorrhage right here in the left temporal lobe. It's very easy to see. But where Rapid really kind of helps to expedite the whole reading process is by giving a lot of these automated measurements by itself. So it gives you the midline shift, so you kind of know how much midline shift you have. That's something you routinely have to measure and report in the radiology report for the study. Then the next thing it does, it will assess how much what the volume of the bleed is. So it's using a hyperdensity based scale, and it highlights all of the areas of hyperdense blood products, and it gives you a volume of how much that total is. So in this instance, the volume is 20.5 milliliters, and that's extremely helpful, and it's going to increasingly become more helpful in clinical practices, as we have recently concluded the Enrich trial, which have shown that intervening minimally invasive intervention in setting of hematomas can drastically improve patient outcomes and length of stays. So now we routinely get asked by our neurosurgery colleagues to help calculate the volume of these hematomas to see whether or not the patient is a good candidate for intervention or not. And Rapid just simplifies the process. Even if I was to calculate this volume myself, I would be very much giving an approximation. But Rapid gives you a very specific measurement, which is far more accurate. A lot of these hematomas end up being irregularly shaped. To do a 3-line measurement and then give a volume tends to be a more archaic way of doing things. So whereas something what Rapid is doing here, giving you the volume by identifying the actual voxels, that's much better calculation and more accurate. And they have shown that in studies as well. So in this first graph here, we see neuroradiologist volume. So board certified neuroradiologists were asked to draw circles around where they thought the hematoma was. Then the rapid hyperdensity did the same thing, and the accuracy for the rapid module was down to 1 milliliter. So it is extremely accurate way of calculating hematomas. What this is also helpful is for helping improve ICH score. So this one study out of CHI Health showed that they were failing to meet the score compliance guidelines by Joint Commission they were consistently around 40% until they implemented Rapid AI tool, and that immediately allowed them to be 100% score compliance. Where this ICA score compliance comes in is the Joint Commission says that for stroke comprehensive centers, anybody that comes in with hematoma, they have to have an ICA score that needs to be documented. Part of that is things like GCS. Then they also really care about hematomas and whether or not they're about 30 milliliters or more. And that's part of the score that goes into patient system. So not only you have to give a volume in order to get the score, you have to be fairly accurate with it, whether or not it's about 30 or cc's or less than that. So getting an automated volume that can be used by the team tracking these scores that can drastically help improve compliance with the Joint Commission requirements. But that's not all Rapid does. It takes a step further. It can really help manage patients longitudinally. So now the same patient who had the big hematoma, you see the big hematoma here, and it since has been evacuated. So as a radiologist, when I'm evaluating this case, I need to assess how much of the hematoma has been evacuated and how much is residual, whether or not there's new hemorrhage associated with it or not. And that can be a bit challenging when the scan angles are very different. Patients move their heads are completely tilted on one scan compared to another. So having a tool that can line things up for me and can help me longitudinally assess how things are progressing is extremely helpful tool for me. So Rapid has the same tool called DeltaFuse. It does a couple of things. First, it will co-register the images along the same plane. So you can see it right off the back that both of these images, this is the current exam, this is the prior exam, they're now lined up at the same level. This makes my life much easier, and really all the clinicians who are trying to make this judgment, they can see how much of the hematoma has really changed. Then the second thing it does, it provides a DeltaFuse image. So what this does, it is taking the prior image and subtracting the current image and tells you what's the difference between those scans really is now. So if you have worsening hemorrhage, you'll kind of start to see there's increased area of hyperdensity. So like in this instance where a patient underwent a hematoma evacuation, their hemorrhage reduced. So you're seeing that there's light pink color here that's indicative of hyperdensity being reduced. So again, it makes life much easier. There's the fact that it co-registers and aligns at the same level, extremely helpful in itself. And this is also helpful for when you're trying to assess ventricles. This honestly tends to be the part where I spend most of my time when I'm reading my inpatient follow-up exams, whether or not the ventricles are similar in size or not. Often, again, these patients have their head is positioned very differently from scan to scan. So having a tool that lines it well up makes comparison much more accurate. I feel more confident that indeed the differences that I'm describing are real. Sometimes when the scan angles are so off, I'm not sure. I will say things like minimally increased to unchanged. And that really gets, once you've lined it up, it gets rid of the ambiguity that exists in my head surrounding the different subtle changes that happen. So in this case, this patient this is their, again, prior exam, this is their current exam. They had this left drain here. Notice that their left ventricle got smaller and the DeltaFuse actually clearly highlights it. Then their right lateral ventricle got much bigger from the prior exam, and that gets highlighted by DeltaFuse too. So it really makes me more confident in my assessment of the case and helps me move quicker through the study. And that's exactly what the data shows, that once you have implemented DeltaFuse, most radiologists were reading the inpatient follow-up scans almost 36% faster. And there is a slight improvement in accuracy too. I think the co-registration by itself just makes life much easier. But where the improved accuracy comes in is subtle instances where DeltaFuse highlights, or there is a subtle subdural hemorrhage that you might have missed if you were scrolling too fast, and it does slightly improve that accuracy as well. Our neuro ICU colleagues and really neuro ICU colleagues anywhere in the country would really find this helpful. They routinely look at their own imaging, so be able to have the prior and the new exams side by side, already lined up by rapid. It pulls those images for you, makes rounding much easier. Then they can look at the scans themselves as well. So really, all in all, a comprehensive tool that not only allows radiologists to help get through cases quicker, but also the ICU team as well. So we kind of seen a case where a patient presented with bleed. We started with a triage where it helped us visualize it, where it helped us identify the bleed initially. Then it helped us visualize it by showing where the hemorrhage was. It did the automatic measurements, and then it also helped us track with the DeltaFuse imaging. So really, the deep clinical AI that truly impacts patient care really should impact health care, the entire pathway from the time they present to the time they get discharged, and that's really what Rapid has done quite well in their schema, where they start from the beginning, patient presenting, and how do they get worked up throughout their stay in the hospital. So next, we'll take a look at another example, and I'll hand over to Sina.
Thanks, Raza. That was great. And yes, I think I want to stress one particular workflow that's near and dear, and that is the aneurysm diagnostic and detection tool and prioritization workflow, which is something I think very exciting for any of us who are in neuroimaging, knowing how much time is spent in looking for aneurysms, the concerns that one might overlook an aneurysm that maybe not even for a year or 2 years, but at some point down the line may present a massive complication for a patient. And this is a major development, I think, in Rapid's portfolio. So what I want to show you here is really the AI sort of driven and prioritized workflow for a suspected aneurysm. This is a workflow that can be conducted and optimized in parallel or in collaboration with your neurosurgical or endovascular colleagues for notifications when a high likelihood case is identified. This can be driven to the mobile application, as you can see. This is just a concrete example here. For those unfamiliar, these are two transverse CTA source images in a patient who's had iodine administered, hence the bright vessels in this patient. This patient has bilateral aneurysms. These can be easy to miss. They can be easy to roll past on a busy workflow, or certainly when there are the additional interruptions and challenges of a busy call shift, for example. And in this location near the skull base, even typical 3D rendering tools can fail to remove the bone in a way that doesn't corrupt or contaminate investigation of the vasculature. Now, on the other hand, the surgical preview within the Rapid AI tool produces these very high fidelity 3D renderings. As you can see here, you have control with full rotation. Around 360 degrees here. You can see that two aneurysms have been identified here. Now you have these cut planes. These cut planes give you a great deal of additional control over the rendering and the representation. The mesh that's been placed and the measurements that have been produced here are entirely automated. This really reduces a great deal of the burden that any of your neuroimaging practitioners would be experiencing in day-to-day practice. And now, as I'll show you in a subsequent slide, this can be done longitudinally, but I want to also give you a sense of how this kind of integrates nicely or synergizes with the Lumina 3D tool, because now you get essentially a complete 3D representation of the vasculature, again, with excellent bone removal and again, with 3D capabilities here. Really relieving your workflow from what typically would either require a full-time 3D laboratory, which many imaging practices may not have, or even for those that do have 3D labs, oftentimes the backlog in the 3D lab, even if you have a 24/7 3D lab, may not necessarily be available at the time that a radiologist is viewing an examination, which is to say they may have to go back and add an addendum at some future time when the 3D labs outputs are made available within the packs. So all of that is obviously deeply inefficient and doesn't really democratize this kind of technology, which is what Lumina 3D does here, again, giving you 3Ds from the arch to the vertex. In terms of the potential benefit of increasing aneurysm detection, again, for any in the audience who are unfamiliar, aneurysms can be very easy to miss. In fact, they're missed quite often. This is a nice study from our Stony Brook colleagues who were using Rapid AI. And they found across a very large retrospective cohort a much higher prevalence of aneurysms in unsuspecting cohorts and standard adult populations, reaching 5%, which was significantly more than the historic axiomatic 3% prevalence in past human studies, really pointing to how much more sensitivity is enabled if you have assistive devices with high sensitivity and specificity. And the first question that comes to mind is its sensitivity for small aneurysms. They did show high accuracy in detecting aneurysms down to 3 millimeters. So really setting a new leading bar for the detection of aneurysms in a really impressive benchmark. Now, they also showed that Rapid was beneficial in identifying 23% more aneurysms. That was 87 more aneurysms in absolute terms in their population, or roughly about 22 more aneurysms identified across each year of this 4-year retrospective study. So really, again, moving the bar for accuracy of what is otherwise a difficult pathology to identify and oftentimes requiring specialization in clinical workflow. The last point I want to make about their study is that the average size of the aneurysm that they found was only 4 millimeters, which is to say an aneurysm for which actionable treatment is absolutely standard in many cases. And so the impact is really quite high. As I said, they had accuracy down to 3 millimeters in their study. You do have the control to set your threshold at a more stringent one. You could set it at 2 millimeters, for example. Obviously, that would potentially engender false positives for things like infundibula and so forth. But the beauty of the configuration that Rapid is allowed in the overarching ecosystem is that the radiologist has control over what does or what doesn't go to the final imaging jacket. So in the event that a practice decides that setting their sensitivity and specificity on a different part of the AUC is beneficial, considering the specialization of their workflow or their busyness and so forth, they do have control over adjudicating ultimately what gets archived within the permanent imaging jacket. And so if you want to be more sensitive, you can do so. You then have control, as we said, with a fully in-context Navigator Pro viewer, which allows the radiologist, whoever the ultimate specialist is, whether or not that should or shouldn't be archived and formalized as a finding, something that might reach a patient in the modern era when patients have access to a lot of their imaging. Now, I also want to stress that not only does it give you that kind of 3D localization and those standard measurements across that mesh, but this has also really enabled an entirely new array of measurements beyond the standard 2 or 3 measurements that are cross-sectional and routine practice, including a lot of volumetric and more advanced geometric representations of an aneurysm and its morphology, the presence of dysmorphia, the presence of non-sphericity, findings that are more and more emerging as potentially more interesting or more predictive, or at least compelling for study than we can really produce in clinical real time. So producing some more advanced measurements would be deeply disruptive to clinical workflow, and that would be even if you had specialists in 3D environments to enable it. But in Rapid, what you'll find from this video is that this process is entirely automated and, again, can allow a very high level of interaction in surgical preview. Now, as I said earlier, this can be scaled up to longitudinal assessments for stability or change. Here are 2 examinations from a patient who had what, at least in the source scan plane, was believed to be a stable or generally stable aneurysm. The radiologist could conceivably, if they had access to more advanced 3D tools, have undertaken what would have been a really time-consuming procedure to compare these in a more sophisticated or expressive way. But what Rapid aneurysm has allowed is really the overlay of current and prior examinations with very advanced rendering tools and also with analytical tools and measurements that allow you to really move beyond what may be your most sort of first level principal axes across the aneurysm in this cross section, for example. And the benefit of this was formalized in a nice recent study by my Stanford colleagues. This was presented at the International Stroke Conference earlier this year, comparing naive versus rapid assisted reads, and then adjudicated essentially subsequently by expert interpretation. And what you'll find from the study was that twofold more accurate detection for the presence of growth, even after subsequent adjudication, was reported with the use of assistive technology in the form of rapid AI. So here again, we really want to show you how the integration or synergy of sort of different modular parts of a larger ecosystem of AI tools can really advance clinical workflow in your practice. I'd like to hand it over to Raza again to close it out.
Thank you, Jennifer. That was a great case and a great module of how aneurysm detection and monitoring those over time is very helpful, having an advanced tool. So today, between Sina and I, we discussed a couple of neuro-specific tools and how depth and breadth meets in this neuro field. In instances of the aneurysm module, we can see from the detection all the way to the follow-up and how AI can truly impact healthcare. And it really goes beyond that. And there are multiple other things in the body where AI can be extremely helpful. And Rapid has several tools that does that, ranging from all the way from mammography to coronary artery calcium scores. And what really makes this helpful and even more broadly applicable is be able to use this tool to not only cross the body, but able to automatically report this into the report, which can drastically help improve my workflow and as a radiologist and help me move through cases quicker in a more efficient manner. Deep Clinical Eye not only provides a clinical benefit, but also allows for increased eligibility for incremental reimbursement. For most part, triage AI tools do not qualify for reimbursement codes, but those that do quantify or generate reconstructions can be eligible. So there are a few different ones that we utilize. So there's a CPT 0722P code, that's a CPT3 code that's eligible for hyperdensity module. This is really the characterization of the tissue, and it reimburses quite well. Recently, the CTP perfusion is now a CPT1 code, and so that gets reimbursed consistently. There's also even ICD-10 code. There's an NTAP code for hydrocephalus, which is really applicable for inpatient exams, which is quite extraordinary. Generally, a lot of these costs are associated. A lot of these reimbursement codes are associated for ED and outpatient exams, but so there's even an opportunity to get reimbursements on this inpatient exams as well. Here's the last video showing you how the clinical workflow works with the Navigator Pro and how it can really help improve the life of radiologists and increase efficiency.
Hey, Rapid, show me a table comparing the current and prior measurements. Hey, Rapid, show me the various different medications this patient is on. Hey, Rapid, show me the prognosis for this patient given other patients with similar findings. Hey, Rapid, start reporting. A 63-year-old male with a history of type B thoracoabdominal aortic dissection, status post-thoracic endograph repair. Non-contrast CT of the chest was initially obtained. Generate report. So in this case now it creates a preliminary report that has all of the information filled in with the various different sections of the report template automatically. Just based upon me speaking freely, what I was looking at while I was viewing the images, and the information that the various agents collected from the prior reports, the history of the patient from the EHR, could also be the various different guidelines and other information that was available for that particular patient. So at this point, I can now send this preliminary report into the reporting system where the physician can then finalize it and complete the patient.
So we have discussed today a platform system by Rapid AI, which really integrates all the way from the triage when the scan is acquired, all the way to the time when patient gets his treatment, and how do we monitor those. And that kind of integration is really what you want, because that puts the patient front and center. It allows for the radiologist to become more involved in patient's care, and while they're working through the higher volumes in a more efficient manner. And having a platform that integrates all of these into one place is really the where we're headed and what we really need in the future. And so with that, I want to thank Rapid AI and Diagnostic Imaging for giving Stina and I the opportunity to talk to you today. And at this time, we'll take any questions if there are any.
We now have time for a question and answer session. If you'd like to ask the presenters a question, please click on the Ask a Question button on the left side of your screen, type in your question, and click Submit. I believe we do have a couple questions that were submitted during the presentation. How do your interventional colleagues view the measurements in 3D? What have their perspectives been?
That's a great question. And I think in large part that remains to be seen because this technology is so new and unlike really anything that exists presently in the marketplace for clinical practice. What we can definitely anticipate is that the inconsistency in aneurysm measurements that an interventionalist or a neurosurgeon, for example, may experience coming from the PACS during interpretations, even by high-level radiologists, can be frustrating. And a lot of that has to be adjudicated in dedicated working cerebrovascular conferences. So, for example, once a week, a major practice or institution may bring together the neurovascular specialists from across disciplines, and aneurysms may be evaluated one after another, trying to assess whether or not there is a meaningful change, whether or not a watch and wait strategy is appropriate, whether or not some intervention should be undertaken, and so forth. What Rapid AI does is that it really standardizes a lot of those measurements beyond anything that can be expected in an inter-rater and quite honestly, even in an intra-rater setting. So this sort of more universal, at least reference standard, I think stands to really simplify workflow for all involved in the care of aneurysm patients. The other point that I really want to stress is that even in sort of the most rigorous settings, what you might often see is a measurement at the aneurysm neck, one from maybe the base to the dome and one across some maximal cross section of an aneurysm dome. But there are many other geometric features of an aneurysm that are not really captured by those three sort of cardinal Cartesian measurements of an aneurysm. And this has been discussed and studied in a number of different settings, but really making that a clinical reality is difficult because how much time can you really expect a radiologist who's sitting under a mountain of acute studies or outpatients to spend creating really nuanced and dedicated measurements. So the fact that Rapid has really made that possible, I think also opens the doors to trials for predicting aneurysm growth, stability, response to treatment, and so forth, with metrics that have not historically been available to us, at least not as practical measurements outside of some really dedicated workflow.
Dr. Mushtak, did you want to add anything to that?
No, I thought that was great. I agree with Sina. I think, it really, the 3D automated measurements really does open up room for a lot of these newer trials where we historically haven't even ventured into because we never had the technology to analyze things at the granular level that we're able to do. And so now.
Okay, another question we had. How do you quantify the value of the automated reporting solution when bringing the business proposal to the CFO?
I think from a radiologist standpoint, the value is it's tremendous. I think one of the most tedious things that I do during my work day is really just reporting measurements, and that can be quite a long process if you have multiple things to report. I know my chest colleagues, when they're reporting lung nodules, they have tons and tons of those, and that can get extremely more even more tedious. And same thing when you're doing metastatic workup, you have to look at the measurements from prior exam, the new exam. So having a tool that automates that will drastically improve our quality as radiologists. But how do we really make the case to the CFO?
Plan
I
to
think,
comp. Sorry, go ahead.
sorry, I think that really comes to but how do we make that pitch to the CFO? I think first, just letting them know how does that improve our quality as radiologists. But what that does is once we are able to automate those measurements, we're able to get through scans quicker, which means that we're able to get through the list quicker, which means there's less of a backlog, which then means then you don't have to hire people after hours. We don't have to send exams out, so it keeps everything in. So there is a downstream ROI on this that can drastically, not perhaps drastically, but certainly help generate some revenue. One of the things where I think this can really help not only not only help the reimbursement sides that CFO would care about, but also help with patient care is just a follow up of it. So, we were discussing how Rapid provides these specific measurements for aneurysm. One of them, and it provides it consistently across the board. Whereas if I did a measurement on an aneurysm, that would be very different from how my colleague does it, and then we may not report the same numbers. Like if I report the medical aneurysm, which neurosurgeons will certainly care about, but my colleague doesn't report that. So now we have incomplete data, or not incomplete data necessarily, but rather differences in how we report things. So having one way of standardizing reports can make follow-up much easier. And this is very true for how lung nodules have been operated. Now, several hospitals have dedicated lung nodule follow-up clinics. So having a consistent way of measurement and reporting them can help the follow-up staff to really be able to help bring the patients back in a not only timely fashion, but in a more standardized way. And so I think not only there's value to for radiologists to get faster using automated reporting, but it can also help with loss of follow-up patients by creating these pipelines and standardization, standardized ways of keeping track of these incidental things like pulmonary nodules or aneurysm, and how do we follow those up.
I think that was very well put by Raza, and I guess I would just only add 2 points. One is that reporting is really central to our making the potential benefits of AI-assisted workflows a reality. We're really only in the infancy of the AI era in radiology, and already many institutions, practices, and groups that were early adopters may feel like they're either drowning under the necessary sort of ancillary workflow steps. You may have to go into a different application, into a different environment that might require logging into different tools. You may be presented with many different outputs, long post-processing data sheets, maps. You may have limited screen space and may have to bring into and out of context an additional set of tools. And then once you end up even evaluating them, you have to make decisions as to what you want to actually place into a report. You may or may not have a dictation system that's already designed to allow templating or the automatic export through FHIR or other based DICOM level standards. So the ability to be able to take a large portfolio of AI-assisted tools, to present them in a way that isn't in and of itself an interruption that might be larger or more significant than time savings that the tool itself is intended to produce is really critical. And so what Rapid has done is they've allowed you to view your results in context without having to leave your native PACS environment. You don't have to pre-commit to what does or doesn't reach the patient imaging jacket. That's really critical in this era because you don't want false positives, false negatives, error messages, and so forth being sent into the patient jacket. You can adjudicate those in real time. You can determine what does and doesn't get added. And then the ability to really automate, and I mean that in the literal sense, to automate the export of those results into your reporting infrastructure. That's really critical in and of itself. And so from that standpoint, I think that reporting, while maybe deprioritized or at least postponed in the view of um, uh, the field more broadly, is appropriately made a critical fundamental part of making tools like this useful in practice. The other kind of brief thing that I wanted to add to Raz's point is that uh, the inter and again even intra-rater variability in interpreting advanced imaging maps and so forth, just like it existed with perfusion imaging, has to be overcome if these are going to become meaningful, consistent clinical tools. And perfusion imaging was in many respects left for dead or was not considered serious technology that was going to advance the field. But by automating the process of perfusion imaging and scoring and creating outputs that were interpretable across disciplines and across domains in real time, Rapid turned perfusion into one of the fundamental parts of care of acute stroke patients. And it's, in my view, likely that trials that had used antecedent technology that wasn't really automating that process and creating fully user-independent outputs may not have been as successful. If you have to wait for 45 minutes for a specialist to look at your perfusion imaging and give you results, you may not get those results in time to have a meaningful impact on a patient's life. So in much the same way, these other AI tools might be subject to some of those same constraints, and finding a way to kind of normalize as a reference standard those outputs in a way that's interpretable, not just to a ultra subspecialized individual, but to the whole of the healthcare environment and patient care team, I think is really a critical part of what Rapid's done here.
Thank you both for that great presentation. We'll be back shortly for our next talk.